95% on 2 liters oxygen. He's alert and oriented. He's reading on his phone. He's got some mild respiratory distress, bibasal rales, no murmur, and he's got significant bilateral lower extremity edema. Okay, so now someone does an ECG on him. Who's going to read this quickly? Very basic, very quick. Who's going to read this? You don't have a lot. You don't have a lot of time, right? He's tachycardic. He's kind of sick, right? My parents read this.
All right. So it looks like he has a rate that's somewhere around 25. He's got a left anterior vesicular block. T-wave inversions in V6. Looks like some left ventricular hypertrophy. Prominent P waves in 2
Good. What do the prominent P waves mean?
So there would be right atrial dilatation.
Right, so atrial enlargement, right? That's pretty good. So he's got tachycardia, basically normal axis, but criteria for left ventricular enlargement. And so this, you have an idea this guy probably has some significant structural heart disease, right?
Left posterior, sir.
Okay.
Left posterior.
Oh, you're right. It is.
All right, so of course, because it's 2020, we go and someone does an ultrasound, right?
Well, thank goodness.
So what you see is B-line predominance at the bases only, a small left pleural effusion, and in fact, you do see moderately reduced contractility and a plethoric IVC. Right, so what kind of CHF does this guy have? Further classifying it. That's systolic dysfunction, right? Good. So we got to reduce ejection fraction. All right, so when you have someone that you're worried about congestive heart failure, you want to classify them into 4 different profiles. Okay, based on the presence and absence of congestion and hypoperfusion. All right. So the bottom 2 boxes are your basically shock patients because they're hypoperfusion, and they could be either they could be cold and dry or cold and wet. Cold and wet are the patients with the worst prognosis. They're the ones that over time retain so much salt and water that they're really not perfusing at all. They're very edematous. And cold and dry is which patient? They're not congested, but they're acute CHF. Those are your unstable tachydyspnea patients, right? Okay. So the subacute in the right 2 boxes, that means it takes some time to retain salt and water when you're upregulation of your renin and angiotensin-aldosterone system. So the right 2 boxes are subacute, the left 2 boxes are acute. Okay, because they're dry patients, they haven't had time to accumulate salt and water. So this is the most common group of patients that we see, patients who are not really taking their medications. They have subacute symptoms, they come in congested edematous, lower extremity edema. And what is the left top box? Which box is that? Warm and dry. This is also very common, not as common. Parents?
I'm not sure.
Okay. Those are APE patients, right? Because they're not really congested, right? They just redistributing volume into the lungs with a serious afterload problem. So that would be in your warm and dry. So which category is this patient again? Soldier?
I believe warm and wet.
Exactly, warm and wet. Good. So this guy's not. This patient's not in shock, so we can actually take some class. We give this guy some topical nitroglycerin, give him IV enalapril to afterward reduce, and gave him. We thought he was hypervolemic, so we gave him furosemide. And then the residents cleared him to the main ED. We put on a monitor and maybe for a CPAP. So of course, over on the main side, he gets worse. gets diaphoretic, lethargic. Here, repeat vital signs. So his heart rate's gone up, blood pressure's still pretty high, respiratory rate's gone up significantly, and he's more hypoxemic. So what happens now? Respiratory finally shows up, they put the patient on BiPAP, and he improves. That lasts maybe half an hour or so. And this is the time when we had a lot of nurses, so patients were being washed appropriately. And the nurse comes up to the physician and says, you know, doc, this patient's having sudden severe shortness of breath, and his heart rate's now in the 170s. So he's evaluated by the physicians there, and they think he needs, he's an APE now, they think he needs nitroglycerin infusion, so they transfer him back to CCT. And he gets put on a cardiac monitor. So over in CCT, here is the vital signs while he's on the non-invasive ventilation. Still not doing great, right? His heart rate's pretty fast. Respiratory rate's in the 30s, and he's hypoxemic. As they're trying to adjust the BiPAP settings, he develops a diaphoresis again that's very disoriented and tries to take off his BiPAP mask. And he takes it off and he coughs up some bloody sputum.
Are we pink frothy or like real blood hemoptysis?
I'd say pink frothy. Good question. All right. So what's your next step in measure? Now I guess I'll ask the senior writers because this is a complicated, complex patient. There's different ways to manage it. But basically, we have a patient who's warm, who started off warm and wet, right? He's got a known systolic dysfunction. He's got these vital signs, and this is his most recent physical exam. So Turner, what do you want to do with this patient?
I said toxic and altered. The low threshold for intubating.
Okay, good. So you want to intubate this patient. Anything else?
I mean, the other thing you could do is sedate him a little bit. Like, if he's like acutely agitated, pulling it off, like non-compliant, but I think I would probably go with EKG.
Okay, so sedate him, what is it, like a delayed sequence intubation to see if he responds to BiPAP better?
We're just people who are independent if he's like lethargic and altered, but if he's like acutely agitated, he's pulling stuff off, like people who you would like asthmatic sometimes.
Okay. So you could sedate him with something that's not going to affect the respiratory drive too much and maybe increases BiPAP pressures and CP tolerance, right? And then Dr. Sinner said ECG, but unfortunately, there's no one around to do an ECG, so you can't get an ECG. Anyone else? You can pretty much go forward with that. Okay, so just like Turner thought, this patient gets intubated. Intubation goes fine. We use accommodates acetylcholine, no complications. Immediately after the intubation, is a repeat ECG is this. Not significantly different from the prior one that we had, right? What's the rhythm, Barons? Just the rhythm.
Science.
Okay, good. So is it science tech? Right. So now, immediately after intubation, he kind of wakes up, starts to try to take out his DT tube. So something, whatever the process happened, it really picks him pretty quickly because his mental status immediately improves and he tries to pull his tube out. And of course, we don't allow him to do that. He gets sedated and he gets put on fentanyl. And then a high-dose nitroglycerin infusion is started, fractional reduction, and he's transferred to the MICU. The next day he's extubated. Probably early in the morning he's extubated. Any questions on that? That's a pretty standard management there. It's pretty good. Patient did okay. And I think he came back later with CHF, but a few weeks later. But here, let's review the resuscitation. so when this patient came over to CCT, it was very chaotic. You know, actually one of the senior residents wheeled the patient over herself and immediately had the RT trailing her with the BiPAP, was holding the mask on the patient to try to ventilate it because she thought he was in cardiac arrest, okay? So as the patient was, and then in the chaos, the decision was made to intubate, which is fine, but they tried to get an ECG, but like I said, there was no ECG available. So what else can you do with the patient in terms of diagnostic while you're setting the patient? We sometimes don't think about this, I think. You can look at the monitor, okay? So this was the rhythm on the monitor. Let's see. What rhythm is this? Well, you can just read it systematically. You don't have to diagnose the rhythm. Turner?
This regular, maybe P waves, pretty fast, complex, pretty narrow.
How fast?
Uh, 140.
Okay, good. So what is your differential in terms of what's overlying this classification? This is a supraventricular tachycardia, right? Which one do you think it is? If you have to guess. You don't have to diagnose it either. You can just say it's supraventricular tachycardia.
SVT.
Okay, well, that is, so you think it's an AV node oriented tachycardia. Okay. So if you look closely, you get the rhythm strip. It's hard to see, but there's P waves there, right? So that makes this atrial flutter 2 to 1. But an SVT would have been fine. It'll help you manage the patient if you diagnose it.
It's right around 150. So think what?
Let's go back to the post-intubation ECG. So you see there is there's your flutter. The post-intubation ECG, you see that there's sinus rhythm, right? So something changed from peri-intubation to post-intubation. What do you think happened?
Increasing vagal tone?
Yeah. Who was that, Barron's?
Yeah.
How did you do that?
Probably by tickling his epiglottis with a heavy hand.
Yeah, so with the laryngoscopy, he probably increased vagal tone and he broke his SVT, which in this case was atrial flutter.
They also release the sympathetic tone when you're sedated.
Right, so there's a post-intubation ECG for comparison, and this is his pre-intubation ECG, which shows the atrial flutter. Everyone following? Interns? Say yes. Okay. All right, so something happened here. We had a patient who was warm and wet. There's some triggers that cause, these are the triggers that cause acute heart failure, okay? So he has some degree of subacute chronic heart failure, and then suddenly he gets some acute change. So this is the guy, warm and wet, basically develops this tachydysrhythmia, which is atrial flutter of 2 to 1. And he probably also had some increased sympathetic drive. So that is going to make his condition worse, right? So this is a figure from View et al., which I recommend everyone read this review because it really explains, volume shifts with acute pulmonary edema. And so what happens is, when patients who have stiff ventricles and elevated BP will have venoconstriction and vasoconstriction. It will transmit volume into the pulmonary circulation. This is typically what we see with our APE patients, our typical APE patients. But our patient has systolic dysfunction, right? A reduced EF. He probably also has some diastolic dysfunction, right? Diastolic dysfunction means there's impaired relaxation of the ventricles. So it doesn't fill properly. So what happens is this guy has somewhat elevated BP, but this guy's BP was probably mostly compensatory, but it was elevated. and he's going to have elevated left ventricular end diastolic pressure. Okay? Patients with diastolic dysfunction, when their blood pressure changes or their arteries get stiff, they can get elevated LVE, left ventricular end diastolic pressures. Okay? And that pressure is transmitted to the lungs, and you get pulmonary congestion. Okay, that's where that guy was when he came in. He wasn't super sick, but he was still needed some management treatment. But then, so how we treat these is we treat with BiPAP, right? How does BiPAP treat these patients? I put it near the preload area to keep you in. So CPAP, you place the patient on CPAP, it increases intrathoracic pressure and will reduce your preload. The other treatment we do is reducing afterload, right? And how do we do that? So that will do it. One dose, but then we usually put them on titrating infusions, right? If they're really sick. And that's where we use like high dose nitroglycerin. Right? Higher doses will reduce afterload. And alcohols also will do it, but this is what we use to really bring down the pressure quickly.
You know, what level do you think nitroglycerin becomes an arterial reducer?
So when I say high dose, I mean 200 to 400 micrograms. But actually, when I manage these patients, I give boluses of 2 milligrams every 5 minutes.
Hey, deSouza, can you pause for a second? We lost your audio.
There's less time for the ventricles to relax. All of that contributes to increasing your LV pressure. Right, so that gives you LV pressures, and then you get pressures transmitted to the lungs, and then when it gets to a certain point, you get pulmonary edema. Okay, and this kind of what happened to this guy, right? He had frothy sputum, he got disoriented, he got very hypoxemic. So he really developed acute pulmonary edema, but not necessarily from the way we used to think about it. He developed it from his tachydysrhythmia. Everyone following that? I don't really feel like I'm scrolling it there. Yeah? Okay. So now let's plug this guy into a familiar algorithm, right? We're almost done. Everyone's seen this, right? This actually worked. Like this will work for this patient, this algorithm. A lot of times ACLS will kind of pigeonhole you in certain ways, but this will work. So you have your warm, wet patient, he develops a tachydysrhythmia, right? Usually the heart rates, they say, are greater than 150, but this guy has some systolic dysfunction. So the heart rate that's going to make him deteriorate might not quite be 150 or be at. Usually you'll see decompensation with much higher heart rates. Now this guy doesn't develop shock, right? He doesn't develop shock. He doesn't develop cold, pale extremities. He's not really unstable in the sense that he's not having end organ hypoperfusion. He has an oxygenation problem because he's acute pulmonary edema. Here they call it acute heart failure. All right. So he says we have this, and so we end up in this box. So Turner thought this patient had AVNRT, right? So actually it counts. They say you can give adenosine because while you're preparing for cardioversion, because if this is an AVNRT, the adenosine will terminate, right? If it doesn't, then you do what? Turner? Right. And so we could have done synchronized cardioversion to avoid, maybe avoid intubating. Everyone follow? Yeah? All right. So in summary, rely on the ECG. So all your interns are going to find out very quickly that you can't get shit done sometimes, a lot of times. So you're going to want an ECG, you're going to be running around, I need an ECG, I need an ECG. So just think that you're not going to be able to get, sometimes you're not going to be able to get it, and think about what else you can do. And the one thing you can do is look at the monitor, right? I think we underestimate sometimes the value that we can get from looking at the rhythm on the monitor. If we had looked at the monitor of this patient, we would have recognized, potentially recognized the patient with a significant tachydyspnea that could have required other management instead of intubating the patient. Acute pulmonary edema may not only be due to excessive afterflow, it might be to a sudden acute dysrhythmia, right? And a paroxysmal tachydysrhythmia may cause an abrupt deterioration, and you may need to address that tachydysrhythmia rather than your usual ABC format or sequence. That's it.